Today, we're going to address a very important subject, very, very important. In fact, you can't go into the exam without knowing this particular topic. But as we always do, we will try our hands on some clinical cases, not related to this specifically, like so that we see our approach. Before we get into the questions, I want to draw attention to something. Somebody will see this and say that, oh, anaphylaxis is no longer applicable. Really, anaphylaxis is applicable. However, that objective was initially objective 921, okay, 9, subsection 2 and 1. But that objective is no longer applicable. It has been placed under allergy and atopy, okay? So you realize that that is where the discussion has gone to now. But before we get into that, so you realize that anaphylaxis now falls under allergic reactions and atopy, and we'll be focusing there. But then before we do that, let's do some random MCQs. We're going to go through some questions, both MCQs and CDMs. And then after that, I go into today's main topic so that we look at some clinical pearls and, you know, what to do and how to prepare for it. So who wants to volunteer for the first case before I bring it up? Dr. Chidubem, thank you very much for volunteering. Dr. Chidubem, let's go. Let's go.
Hi, everyone.
Hi.
So since a 43-year-old hiker is attacked by a group of wasps and develops sudden wheezing and shortness of breath with tachycardia, what is your best initial treatment?
Beautiful.
A, intravenous steroids with antihistamines. B, epinephrine intramuscularly and antihistamines. C, epinephrine intravascularly and antivenom. D, remove the stinger and give a non-steroidal anti-inflammatory agent. E, venom immunotherapy and discharge the patient with a prescription of EpiPen.
Okay, so Dr. Chidubem, what answer are you going for? Because people are sending me interesting answers. So far, I've received how many answers? 1, 2, 3, 4, 5, and it's going.
I'll go with
place. So what are you going for?
B.
B. B for boy, or D for daddy?
No, B for boy.
B for boy. Okay. So why did you not go for IV steroids? Usually when I'm teaching, that's what I do. I don't want you to just choose an answer because it could also be random, right? Why did you not go for IV steroids with antihistamines? Why didn't you go for epinephrine IV and antivenom? Why didn't you go for D? Why didn't you go for E? Why did you go for B? In fact, B is correct, but why did you go for that?
Because I know that's like part of the treatment protocol for anaphylaxis, and giving epinephrine intravascularly is probably going to lead to cardiac arrest because someone's speaker is on.
Okay, sure.
Anyway, I'll just continue.
I'll mute the person, yeah.
I'll just continue. Anyway,
continue.
I think giving epinephrine intravascularly is going to lead to tachycardia because he's already having tachycardia, and epinephrine is a vasopressor, so I don't think that's going to be like the right thing to do, except maybe if he's like hypotensive or something, then I would give epinephrine intravascularly. So but I know like part of the treatment protocol is epinephrine, antihistamines, steroids, and yeah.
Okay, so if steroids are there, why didn't you choose A? And then the epinephrine as well has B is IM and C is IV. So why did you choose IM per se? I'm just wondering why you went with that answer. Yeah.
Yeah, because it might not have as much of a drastic effect as IV epinephrine. And since he's already tachycardic, I don't want to make his heartbeat go so fast. So
okay, sure.
I'll give it IM.
Okay, good. Dr. Priya, you raised your hand. Did you want to say something?
Yeah, hi. So I would go for A because now the 43-year-old has already got a wheezing and shortness of breath. So that means there is laryngeal edema already. And because there is a tachycardia, I wouldn't want to give epinephrine. I would prefer to give intravenous steroid, reduce the edema of the laryngeal wall and combine it with antihistamines.
Okay,
I wanted to say that. Your discussion, please.
but what
Thank
is
you.
this patient presenting with? This patient is basically presenting with anaphylaxis, okay?
Anaphylaxis, yes.
The patient is presenting with, so what is the first line treatment in anaphylaxis? Is it steroids and antihistamines, or is it epinephrine? And the epinephrine, which route? So you realize that this is what I was talking about. You know that you need to give epinephrine. You also know that you may need to give an antihistamine. But then look, the way the question has been placed, it makes it really difficult. And Dr. Priya, I really get your line of reasoning, which is really true. And that is why we are doing what we are doing. But the answer is epinephrine IM and antihistamine. If a patient comes into the hospital with any form of anaphylaxis, the first thing you want to give is epinephrine. And I also saw the way Dr. Chidubem was going through her reasoning for why she's going for IM and not IV. So this is what we do. If somebody has anaphylaxis, this organism, they could have just said, okay, the patient had a bite from a hymenoptera. They could have just said that. A wasp is a hymenoptera, a bee is a hymenoptera, okay? And it must be treated like any other anaphylaxis. IM epinephrine is the mainstay of treatment. And then you can consider H1 and H2 receptor blockers, which can be good adjuncts, but they should not delay the delivery of epinephrine. Now, the other question is, even with IM and IV epinephrine, which one is easier to give? Because with IV, you have to now set the IV line and give it. But with the IM, you can just plunge it into the thigh and then give it, like the EpiPen. You just put it in there, boom, and then you give it, okay? The other issue with the other answer options is that steroids will be given. In your management of anaphylaxis, you will give steroids. But the reason why you give steroids is because it causes delayed reaction. Steroids cause or prevent the delayed reaction. So in the acute phase, somebody I can't breathe. Doctor, I was bitten by a bee. You may give steroids, but steroid is not your first line. And don't forget, in the QE1 exam, that is one thing you are being tested on. First line treatment. What's your next best step? What's your next best investigation? Okay, so you must know first line stuff. Now, beta agonists like Ventolin and the rest are also given, but not the first line medication. Even if the patient is having wheezing after the patient has been bitten by a bee, you want to go ahead and give your IM epinephrine. Now, let's come back to Dr. Chidubem's IV epinephrine and why she went away from that to give the IM. IV epinephrine can be given in anaphylaxis, but it is reserved for patients whose symptoms are refractory to initial treatment and also patients who develop cardiac arrest. Because remember that in your cardiac arrest protocol, ACLS, when the patient has PEA arrest or pulseless ventricular tachycardia, you give it. Even patients with ventricular fibrillation, you give epinephrine IV, okay? But then in this case, give your IM epinephrine first. Then the last question, the last answer was saying you can discharge with epinephrine auto-injector, but that is not your first line. You know, the patient is dying. You want to manage the patient first, make sure the patient is stable. And in fact, even after you give your epinephrine, you want to monitor the patient for about 4 to 6 hours in the emergency room before you can say that, okay, you are going home. These are going to be my discharge instructions. I'm going to give you this. I'm going to give you that. I want you to touch base with your family doctor, you know. But for now, for when you are starting, you want to give your IM epinephrine. And when a patient is going home after they've had anaphylaxis, you also want them to go see a specialist for anaphylaxis or allergy testing. And they may get, you know, immunotherapy or, you know, allergy desensitization. So these are the steps you want to go through. First, give your IM epinephrine. You can give your H1 receptor blockers, H2 receptor blockers like beta agonisol, like your Ventolin, if the person has wheezing, but IM epinephrine is okay. I want another volunteer. So we've gone through anaphylaxis treatment in general. When you give IV, why IM is the first, why steroids is not the first line, IM epinephrine is the first. So who is next? Who wants to volunteer again? And then we go on to another question. I need another volunteer. Yeah.
I will.
Okay, Dr. Priya. All right, let's go.
Excuse me. Can you please, whoever is not speaking, can mute yourself, please? Thank you.
Okay, sure. All right. Thank you very much. Dr. Priya, let's go.
An otherwise healthy 30-year-old woman comes to the clinic with a history of ongoing fits on coughing and trouble catching her breath with a whistling noise, noisy breathing. Vitals BP 120/80, respiratory rate is 16, SpO2 is 95%. What is your next best step? Spirometry, chest X-ray, arterial blood gas, methacholine challenge, chest CT.
Good. Dr. Priya, what will you go for? 30-year-old woman.
So she's 30-year-old and her vital signs are normal, and she is having excessive coughing, and she is having sort of a stridor. So what is your next best step? So I will think about the, I will do chest X-ray because if there is a stridor, I would like to think of a foreign body. So probably I'll go for a chest X-ray.
So the question says the patient has whistling, noisy breathing, not stridor per se. So whistling.
Okay, so that could be a wheeze. If it is a wheeze,
that is likely a wheeze,
Yeah, so I would, if it is a wheeze and her vital signs are normal, it means that the patient is still stable and she is still coughing. So I would like to go for spirometry is a big procedure. So I would like to go for something like a methacholine challenge to decide whether it is going to be asthma.
So if you want to determine if a patient has asthma, methacholine challenge and spirometry, which one will you go first? And spirometry is a simple test. You just give them something and they blow. I think you are thinking about pulmonary. I think you are thinking about pulmonary function tests. That is different.
Yeah.
Spirometry is just a spirometer, like they'll just give you something, you blow into it.
Oh, the peak flow meter. That's a peak flow meter.
Yes.
Yeah, if that is it, I would go for spirometry. Yes.
Beautiful, beautiful. And because look, what are you going to get from the arterial blood gas? The patient is stable. What are you going to get from a chest X-ray? It may not really show anything. Methacholine challenge is not your first line. Chest CT scan, this patient is wheezing. Most of the time, the chest CT scan is not in the emergency room. You are now going to move this patient who is stable right now, and you're going to move the patient into what we call the tunnel of death. That is the CT scan machine. Okay? So when you are choosing your answer, I like the way you thought through it. Chest X-ray, is it really going to change my management right away? But spirometry can help me to give me whether it is an obstructive picture, right? Or a restrictive picture. A spirometry alone, it will be able to, and it can be done by the bedside. All right? So in this case, you go for spirometry. And the teaching point is this. This patient has symptoms of bronchospasm. Spirometry will be essential. And the spirometry will help you to differentiate whether it is obstructive or restrictive. Okay? If the spirometry is normal, because this patient's presentation is mild, as you said, the vitals are stable, then you want to consider the methacholine challenge test. But you don't let the methacholine challenge test lead you. Now, the chest radiograph and the chest CT is not indicated at this time because of the lack of constitutional symptoms, because the patient does not have, any fever or anything. Even if it's a foreign body, what will a chest X-ray show you anyway? Most of the time, with the initial presentation of foreign body aspiration, the chest X-ray may be normal, all right? And then obtaining an ABG may be helpful if the patient presented with respiratory distress, because then you want to find out, is the patient in respiratory acidosis, respiratory alkalosis, but this patient is stable. This patient's oxygen saturation, let's go again, is 95%. Dr. Priya, are you getting the whole point? Hello, Dr. Priya, are you there?
Wonderful. Yeah,
Oh.
that was a wonderful discussion.
So,
yeah,
so
I
this is
really
how
got sidetracked with that spirometry thing. I took it to be the pulmonary function test. That was
exactly. Now, before we move on, I think Dr. Ellie and Dr. SS have questions. So, Dr. Ellie, you raised your hand. Please bring up your question. Dr. Ellie? If not, Dr. SS, please bring up your question.
Hi, hello. First of all, English is not my first language. Can you go back? I don't understand what does the feeds mean. The feeds means time. Ongoing feeds. Feeds.
Oh,
feeds.
Ongoing fits. Fits is like ongoing episodes.
Episodes. Okay. I feel like the clinical scenario is a little bit awkward in my perspective. I'm not sure how you feel it. 30 years old woman, and they don't even know. Usually, I mean, if it is asthma, I choose A as well. Even though I feel like none of the choices will be perfectly matched, because usually children, they know they have asthma in their child time. Usually not that late. So that's something that I feel a little bit awkward. It's rule out A because it's obviously it's not right. It's not the patient does not have any fever. There's no indication for the chest X-ray. It's obviously something wrong with trachea. It's obstructive something, and it's not definitely not C because it's not the indication. ABG is a very invasive investigation. Unless we really need it, we don't want it. D is kind of yes, we can rule out that one, but we can rule out C, E, and B based on the clinical scenario because the patient is stable. However, I just a little bit wonder why the 30-year-old woman, she doesn't know she has asthma.
Okay, so that's a very good point. Look, in the QE1, this is what you are going to see. A lot of the clinical scenarios are not straightforward. Number two, not everybody who has asthma knows it from childhood. Some people may never know their trigger for the asthma until they've grown older. Okay, so the issue about, oh, asthma is always picked up in childhood, no, that's not the case all the time. And it was a good point you made, but the Q1, if you go try the MCCs, their test questions, and you realize that the questions are very vague. And most of the time, you'll be able to rule out about 3 of the options and you'll be left with 2. And then that is when you have to know how things are done in Canada so that you can be able to choose the best answer. Dr. Ellie, do you have any question there? Because you raised your hand. If not, we can move on.
No. I mean, sorry. I mean, this question for me it looks like because we don't need any management, just let the patient leave whatever the trigger factor it is, or it may be I can't suspect this patient is a little is it anxiety case as well, because if you get anxiety,
okay, so let's take our time. If a patient has anxiety, they will not cough. Okay, if a patient has anxiety, they will not have whistling, noisy breathing.
Yes, you're right. Okay, thank you.
So if a patient has anxiety, and I think you're talking about panic attack, if they have panic attack, they'll rather be sweating. They have what you call students fear 3 C's, like they'll be sweating, they'll be tremulous, they'll be unsteady, they'll have an out-of-body experience, they fear impending doom, okay? But they wouldn't have whistling sound when they are breathing. They wouldn't have cough. So there are things which will rule out anxiety. And even if it's anxiety, none of the answers here will help you to really know that. But look at somebody who is coughing, who is having difficulty catching her breath, who is whistling or having wheezing. It tells you there's something wrong with the airway. So if there's something wrong with the airway, is it restrictive airway disease or obstructive airway disease? And one of the things which can help you very well is spirometry. I always teach my students, my candidates, and even the residents I teach from the university that, look, when somebody comes in, remember two numbers, 0.70 and 0.75. 0.70 and 0.75. And usually I teach it during my asthma class. 0.70, it leans towards COPD, and 0.75 usually leans towards asthma. Okay, good. Dr. Belinda says, this gives me an impression of asthma, severe probably. So why don't we do metacholine challenge test first before spirometry? Because the metacholine challenge test, you will need to assemble stuff. Spirometry, you can just do it while the patient is in the bed. And usually spirometry is your first line. Spirometry is your first line. Metacholine challenge test is not done often. If spirometry gives you the answer, you go ahead and manage the patient. All right. And you are saying it looks like the patient is severe. She sent a private message. But if you look at the patient's vitals, blood pressure of 120/80, respiratory rate of 16, SpO2 of 95, this patient, you can buy the patient some time. All right. Good. Let's go on. I need another volunteer. Who, Dr. Ruby? Okay, Dr.
Yes.
Ruby.
Yes. Hello.
Okay. Yeah, I'm listening.
You are seeing to see a 39-year-old G5P3A1 SA at 30. SA is spontaneous abortion. Okay, one is spontaneous abortion at 37 weeks gestation for her prenatal appointment in a rural Ontario clinic. She informs you of visual blurring and then starts seizing on the examination bed. Her BP was 179/96 millimeter of mercury. What is your topmost diagnosis?
Okay.
Gestational hypertension.
Why gestational hypertension? This patient is seizing.
Seizing and eclampsia, basically.
Eclampsia, beautiful. Okay, so I just want to stick with you because this is a CDM, okay?
Yes.
It's eclampsia, it's straightforward. Now, what other diagnosis will you consider? In other words, this question is asking you differential diagnosis for eclampsia. And this is where I want to see how you're going to reason through it. What are your differentials for this patient? What other diagnosis will you consider? List 4.
Okay.
What diagnosis will you consider?
Like she's seizing, she's one is the gestational associated or any past history, family history, HELP syndrome.
HELP syndrome. Does HELP syndrome cause seizure?
No.
Okay, good. So basically, you see, you have to understand the question. What other diagnosis will you consider? If you come to a clinic, somebody having a seizure, what differentials are you thinking about?
Professor, I want to say something there. People are writing in the chat box and it is coming on the screen. So it's somewhat distracting, you know.
Oh, okay. Please send me your answers privately. Okay, please send the answers privately to me, to MedCognito. Don't send it in the general comment section, or else you confuse them.
Yes, yes.
Okay, Dr. Gupta, let's go back. So somebody is having a seizure.
Yes.
What are your differential diagnoses?
One is like it is, first of all, it is whether it is related with the pregnancy or is the medical disorders. If we talk about the medical disorders, like patient is eclamptic, itself history of eclampsia is there.
Okay.
Or other conditions,
somebody with seizure.
Right now, that is
somebody with seizure. Think about it. Let me.
Or some history of cardiovascular incidents.
Sure, that's fine. Let me share my screen and take it, because I think that I see people struggle with some of these things over and over again. Can you see my screen? I took the PowerPoint off. Good. Usually there's an acronym I teach my like medical students, residents. I teach them this acronym. I call it DIM phases, okay?
Okay.
DIM phases. And you can use DIM phases to generate every form of differential diagnosis you want to generate. Okay. So now let's start from here. DIM phases, usually the D So, and you are going to use it to generate it and for me to see. Usually the D stands for drugs. So tell me, do you know any drugs which can cause seizures? And it can be drug overdose or drug withdrawal. What about a patient who drinks alcohol and has not drunk alcohol for the past 2 days? If the patient has alcohol withdrawal, can that cause a seizure? Yes, right?
Yes.
Because if alcohol withdrawal becomes very bad, delirium tremens. Okay, the M in dim faces stands for infection. Which infections can cause a seizure?
Meningitis.
Beautiful. Meningitis and what else? What about encephalitis?
Yes, encephalitis.
Beautiful. Okay, good. So we've looked at 2. The M stands for metabolic. Okay. Dr. Gupta, I'm happy you are doing this. And I'm sure you will never forget this. Give me at least one common metabolic condition that can cause a seizure.
Metabolic conditions like hypercalcemia.
Don't even go there. Don't go there yet. Don't go there. One metabolic condition, yes.
Like ketosis. Ketosis.
Well, ketosis.
Hyponatremia.
Well, hyponatremia. Yes, hyponatremia can do that. What about a patient with low blood glucose, hypoglycemia?
Yes, that's
so. Look, so hypoglycemia. In fact, if anyone has seizures, you've got to rule out hypoglycemia even before you do any other thing.
Okay.
That is. So look, even by going through DIM, D-I-M, how many differentials have we gotten? Alcohol withdrawal, meningitis, encephalitis, hypoglycemia. Okay. And then somebody said hyponatremia as well. Okay, let me clear my page. Now let's go to the faces. F, functional. What functional condition can cause a seizure? And functional, you can think from the head to the toe. Can something in the brain cause a seizure?
Yes, any brain tumor or...
Oh, brain tumor, beautiful. So brain tumor, okay. What about A? Usually the A, we say anemia, but anemia will not necessarily cause a seizure. But this is how we generate differentials, okay? C does not usually apply. E is electrolytes. So let's go back, electrolytes. Which electrolyte abnormality can lead to a seizure?
Like someone said hyponatremia.
Hyponatremia. Now, S stands for seizures and space-occupying lesions. So you see, by using dim faces alone, we've been able to generate our differentials. For example, Dr. Gupta, let's take this again. This is outside what we are doing, but let's using dim faces. A patient comes to you with shortness of breath.
Okay.
Let's even do chest pain.
Yes.
Use dim faces. Chest pain, dim faces. Which drugs can cause chest pain?
Like in the medicine, D for drug, even the alcohol withdrawal or excessive intake of alcohol also causes...
well, sure. But what about cocaine?
Cocaine, yes. Second is a cocaine.
Good. So cocaine, okay? Which other drug can cause chest pain? If the patient takes amphetamines, right? Amphetamines, like they can have heart racing and chest pain, right? Okay. What infection can cause chest pain?
Infection like
pneumonia. Beautiful. Pneumonia can cause chest pain. What metabolic condition can cause chest pain? Is there a metabolic condition that can cause chest pain? Not really. Maybe there are others, but let's look at this. Faces, functional. What functional condition can cause chest pain? Like something happening. What about myocardial infarction? Hello, Dr. Gupta.
MI, yes, MI.
Beautiful, you can get MI.
Yes.
I've just gone outside what we are doing. I'm just teaching you how to generate your differentials. So chest pain, what are the things in the chest? The heart is there. What else can happen to the heart that can cause chest pain? So we've talked about MI. What about cardiac tamponade?
Like valvular disorders, any valvular lesion?
Sure, but what about cardiac tamponade? Cardiac tamponade.
Cardiac component, arrhythmias, tachycardias.
Well, tachycardias will not necessarily cause chest pain unless
Arrhythmia,
it is
chest pain,
associated with something, right? So what about myocarditis, pericarditis, endocarditis? The patient will have chest pain, right? So even when you look at the heart alone, then we go to the lungs, and someone said pneumonia for the infection, but in the lung as well. What about pulmonary embolism? Would the person have chest pain? Exactly. Okay, what are the other things in the lung apart from the lung, the heart and the lung? What about the esophagus?
reflux?
Reflux disease. Beautiful. Reflux disease. What about rupture of the esophagus? We call that Bohav's syndrome. Would a person have chest pain?
Bohav, okay, yes, I have, sorry, I'm not able to recollect it. Can you spell
that's fine,
it?
don't worry. If the person has esophageal rupture, would that cause chest pain?
Yes, hiatus hernia.
Sure, and acid reflux, right? Okay.
Yes, acid
reflux.
reflux.
So now let's move away from what?
Sorry, doc.
Yes.
Sorry, doc. Borhave's causes retching, severe retching.
Yes.
And chest pain might not be the main factor. Severe retching and hypotension.
No, but we are just talking about, Dr. Priya, we are just talking about things which can lead to chest pain.
Oh,
so
okay.
No, listen to me. Bohav's does not cause retching. It is the retching which rather causes Bohav's. So the person will retch, and then the esophagus will tear. The content of the stomach will start getting into the lung, getting into the mediastinum, and then the person will start developing the chest pain. Okay, so that is one. You can go check it out. Bohav's syndrome can cause chest pain. You can also check something like esophageal spasm. Will that cause chest pain? Beautiful. So we are talking about the functional. We are done with the functional. Let's go to electrolytes. The E. Are there any?
Can we say musculoskeletal, muscular pain?
Muscle pain. Even herpes zoster infection of the chest, right? Herpes zoster. If the person develops herpes zoster infection as well, that person can develop chest pain as well. Okay.
Pleurodynia.
What?
Pleurodynia.
Yeah, pleurodynia. Yeah. And then what about even trauma to the chest? So if you even use dim phases alone, dim phases, if you have to always list differentials, dim phases alone can help you. Today, I just want you to know how to generate differentials on the spot. Thinking outside the box, you may not even know it. So for example, somebody with shortness of breath, how would you use dim phases? Which drugs can cause it? Which infections can cause it? Which metabolic conditions can cause it? Okay, so now let's go back to this question. What diagnosis will you consider? What diagnosis will you consider?
It is we can say PIH with eclampsia.
Well, we've said that already. We said eclampsia as the answer here. So the question says what
other diagnosis is alcohol, like alcohol withdrawal.
Beautiful. We've already talked about all that.
Hypoglycemia is very common in pregnancy. Or it can be meningitis.
Beautiful. What else? And, so it could even be hypertensive encephalopathy. It could be pheochromocytoma. It could be a stroke. A stroke can lead to seizure. It could be space-occupying lesion. It could be a space-occupying lesion which is leading to the hypertension, not necessarily preeclampsia. Okay, it could be hypoglycemia, syndrome of inappropriate ADH secretion, meningitis, encephalitis, thrombotic thrombocytopenic purpura, idiopathic epilepsy, use of illicit drugs, cerebral vasculitis. So you see, if you take your time and think through your questions, you can easily generate a lot of answers on the spot. Okay, Dr. Ruby, let's go again. So this same patient, after you've listed your differentials, after you know that this patient has eclampsia, what will you do next? Now, take your time. Take your time. don't rush with this one. The question says that you are seeing a 39-year-old female who is 37 weeks in a rural Ontario clinic. The patient starts having a seizure on the examination bed. What will you do next?
I will like to do urine albumin. If it is positive, it is more directly indicating that it is because of pregnancy-related reason, and then we can give her Magself and eclampsia-specific treatment.
Okay, I have a question. Can you give Magself in the clinic?
No, we can yes, like intramuscularly.
But do you have Magself in the clinic?
No.
You don't have Magself in the clinic. Where do you get Magself?
Lapitalol IM?
No. But you don't have all those medications in the clinic. In Canada, we don't keep labetalol in the clinic. We don't keep magnesium sulfate in the clinic, right? I'm trying to lead you to something. This question says this happened where? In a rural clinic.
Refer the patient.
So move the patient to the emergency room. Call an ambulance and transfer the patient to the emergency room.
Yes.
You see the way people lose marks in the exam? Okay. Because they forget the clinical setting. The question can be in the person's home. It can be in the clinic. It can be in the emergency room. It can be even on a hospital, a regular hospital ward, an inpatient. You can't give mag sulfate in the clinic. If you give mag sulfate, how are you going to monitor the person's respiratory rate? How are you going to monitor the person's deep tendon reflexes? How are you going to monitor the person's urine output? Because if you give mag sulfate, you need to monitor all these, right?
Yes.
So this question is drawing your attention to the fact that it is not every answer which is give a medication. At times, the answer basically will be that change the person's clinical setting. This thing occurred in the clinic. The next best step is move the person from the clinic to where? To the emergency room.
Yes.
Dr. Gupta, are you with me?
Yes, certainly. I'm totally, and I'm really, yes. I appreciate the way you are taking this question and making us understand. Yes.
Exactly, because this is my fear. I know you know your stuff. I know you know that you need to give mag sulfate and all those things, but you don't keep mag sulfate in the clinic. Magnesium sulfate is a serious medication we give to patients who have torsade de pointes, who have like status asthmaticus. We don't do that in the clinic. It is done in the emergency room.
Yes.
Are you following me?
Yes, certainly.
Good. If you don't even get anything from today's session, how to generate differential diagnosis and being careful with the way you answer questions.
Yes.
Will really, really be beneficial. Okay, now stick with me. So we are going to move this patient to the emergency room. Now the question says, what other symptoms may be present in this patient? So in a patient with seizure, eclampsia, what other symptoms may be present?
Nausea and vomiting.
Okay, sure. What else?
LOC.
Loss of consciousness.
Yes, or stupor.
What else? Can they complain of headache?
Headache.
Yes.
Okay. Can they complain of right upper quadrant pain?
Epigastric pain, right hypochondrium pain.
No. What did you say? You said right hypochondriac pain. No, right upper quadrant.
Upper quadrant. Okay.
Yes. Okay. So you want to be very careful. So if somebody has eclampsia, why are they having persistent headaches? Because of the scotoma they can develop. Why are they having photophobia? Because of everything going on. Why are they having right upper quadrant pain? Because the liver can be stretched. Stretching of the liver capsule. Why are they having altered mental status? Because they just had a seizure.
Hypoxia.
It could also be because of hypoxia, but most of the time because of the seizure. So you see, please, I want to really communicate this thing clearly. Let's be careful about the way we answer our questions. We may know, but if we rush into the question, we will get it wrong. Before we move on, Dr. SS, you have a question. You raise your hand.
Okay.
Yes, thank you, Dr. Matt Contico. My question is, if you can go back to the question, my question is just very simple and straightforward. If the question didn't say it is in a rural Ontario clinic, if it is in the hospital setting, can we just give the medicine directly?
No, you can't, because typically in Canada, I'm in the clinic right now. We don't have max sulfate here. That's not a typical practice. This question,
I mean, if I was working in the hospital.
Oh, sure. If you were in the hospital, if the scenario said the patient was brought to the emergency room, then of course, if the patient is in the emergency room, you don't now go and get an ambulance to send the patient to the emergency room again. That's when you go ahead and give the medication.
Even though I'm not ONG specialist, I can still treat the.
You don't need to be an ONG specialist to give magnesium sulfate.
Yeah, that's all my question. Thank you.
Beautiful. Awesome. Okay, so let's go back, Dr. Ruby. Stick with me, okay?
Yes.
Because we are learning a lot of things. So,
Doc, 1 minute, Doc, 1 minute.
Dr. Priya, ask your question. You are muted, Dr. Priya. We can't hear you.
Oh, I'm so sorry. So suppose in the scenarios in the hospital, which injection would we choose? Would you choose a Maxulf first or a labetalol first?
You give max sulfate first. In a patient who is season, you give max sulfate first. Yeah. Because don't forget, this question has not even, the question has given you the blood pressure, but you give max sulfate first. You give max sulfate first.
Thank you.
Okay, sure. Okay, so Dr. Ruby, let's go on. Let's go on with the question.
Yes.
So what investigations will you request after the airway, breathing and circulation have been stabilized? So remember, like, if the question has said, what will you do next after the patient has been sent to the emergency room? You say, I want to stabilize the airway. I want to make sure breathing is intact. I want to make sure. Now the question has taken that away from you. The question says, airway, breathing and circulation have been stabilized. So what investigations will you request? Now, take your time. Take your time. In a patient, now when you have a patient, always ask yourself, what investigations can I do at the bedside?
Sugar.
Exactly. Now, take your, who said sugar? Dr. Priya.
Yes.
How will you state your answer for sugar?
What is that? Pinprick or what is that? Rapid glucose test or glucose monitor test.
No. So just say rapid glucose test or what we call AccuCheck, okay? Or some people also say capillary bedside glucose. Now, if in this case you say serum glucose, serum glucose means the blood has to be taken and sent to the lab.
Yeah, centrifugation.
And when are you going to get the results? It will take a long time. But if you say capillary bedside glucose, then as soon as you prick the patient, you just put it there and then you get your results and you know whether the patient is hypoglycemic or not. So what I'm trying to say is this: whenever you are answering questions on investigations, ask yourself, what investigations can I do at the bedside first? Bedside.
Urine first, urine dipstick.
Okay, so no, but let's start from here. The urine dipstick will only, wait. The urine dipstick will only confirm the fact that there's protein, right? But then what lab or what bedside test, if not done quickly, can kill the patient? That is the glucose, right? The capillary bedside glucose. And then you can also do your urine test for protein, right? And then what else can you do?
Bleeding time, clotting time.
But sure, that is also an answer. I'm talking about the things you can do at the bedside. Can you do an ECG?
ECG.
Beautiful. Can you also check the fetal heart rate at the bedside?
Yes.
Beautiful. So you see, if you take your time, you can do, and then of course, I'm not saying your answer is wrong. PTT is right. You may want to check the creatinine level. You may want to check the urea level. You may want to check LDH, all those things. But I'm saying that the question can also be that, what bedside test can you do? Okay, so now let's go back. So we can do our serum platelets, which is right. We can do our PTT, we can do our INR, we can do the fibrinogen. Why? Why are we doing fibrinogen? Because we want to check for
Help.
LFTs, right? And HELP syndrome. You want to check your ALT, your AST, your serum creatinine and serum uric acid. Why? Because preeclampsia can lead to renal failure, right? You also want to do your 24-hour urine collection for the albumin creatinine ratio. But even in these answers, I should have added ECG. I should have added capillary bedside glucose. Please, are you getting me?
Yes.
Yes, beautiful.
Okay.
Beautiful. Beautiful. Dr. Marjan, you said termination of pregnancy as soon as possible. Maybe you wanted to mean delivery of the baby as soon as possible. Termination of pregnancy is totally different from delivery of the baby. Okay?
Yeah, you'll have to be careful with the words that you choose.
Exactly.
You're right.
Be very careful.
Excuse me.
Yeah.
Whoever want to speak, could you please raise up your hand and then speak? Could you respect a little bit, like give a little bit respect to other people?
Okay, sure. That's good. That's very good. Okay, sure. Let's continue. So 37 weeks eclampsia, you want to prepare for delivery. Okay. Okay, let's go on. So the question again comes, what bedside test will you do? So Dr. Gupta, back to you. This time,
Yes.
remember, we already talked about it. Capillary bedside. Look, be careful about the way you answer your questions.
Yes.
People get low marks in the QA1, not because you know, like the way you were answering your question. I know you need to give mark sulfate and all, but even before you get mark sulfate, you see where the questions are going. We've not even talked about mark sulfate yet.
Yes.
Capillary bedside glucose, ECG, urine dipstick for protein. Because if you say urinalysis, or if you say, let me not say urinalysis, if you say urine test for, because there are a lot of, you can also do a lot of things with the urine test, but urine dipstick can be done at the bedside. You can also do a bedside ultrasound.
Yes.
Because you can just move the ultrasound to the bedside and do it, right? Good.
Yes.
So be careful about the way you choose your answers. So
Yes.
that was a quick review of how to answer questions, and we've already done almost 54 minutes. I'm now yet to teach the anaphylaxis alone. Dr. Gupta, what lessons have you learned from this encounter? What lessons have you learned?
First of all, after reading a question, it is very important to give time to analyze one. Be careful about the words we are using, and very important is how to give differential diagnosis by using the dim face, which is absolutely suiting me when we get dim on our DD, differential diagnosis. So dim face is always, I will remember it. This is very important. And second, whenever we plan for the investigations, we always give a thought, is a bedside or a laboratory, is an emergency case. So preferably in emergency, we have to be bedside, and it is very important where the case is happening, whether it is in the clinic setup, condition, environment where we are seeing that patient. Scenario is given at home, clinic, long-term care home, or it is a hospital scenario. And thirdly, be careful about the investigations and the treatment. Like, as you said, the words should be very carefully chosen.
Beautiful, beautiful, beautiful. And you realize that we did not even get into magnesium sulfate, complications of magnesium sulfate, what you should watch out for in a patient with magnesium sulfate, where you are going to check the deep tendon reflexes, the respiratory rate. In fact, there are so many ways you can be tested so far as eclampsia is concerned.
Yes.
I just wanted, and in within 1 hour, we've not even gotten to the management of eclampsia yet. But look at the lessons which have come out of it. So what I want you to do is, look, over the weekend, take your time, take the objectives, take the big issues, chest pain. Assuming I'm asked chest pain, how am I going to generate my differentials? Headache. How am I going to use dim phases to generate my differentials? Leg pain. How am I going to use dim phases? Abdominal pain, pelvic pain, okay? Loss of consciousness, fever with confusion. We call them hot and crazy. How am I going to get my differentials? Lethargy. How am I going to get my differentials? Because these are all major MCC QE1 objectives.
Okay.
Eye pain, visual blurring, difficulty swallowing.
Yes.
Doctor, so you realize that it's not all about I've picked Toronto notes and I'm reading. No, it's about the approach. If I get a patient with seizure, what is my approach? If I get a pregnant woman or like a pregnant woman with seizure, what is my approach? If I get a young boy with wheezing, what is my approach?
Yes.
Please, you know, I always want to plead with candidates to take their time. Let's not rush into questions. Let's get into the teaching session. I'm going to teach the anaphylaxis as well. I know we've dealt with it in the question, but let's get into it again. So anaphylaxis was initially, when they started the QE1, like it was an objective on its own, but now it has been added to allergy and atopy. So for example, if you get to allergy and atopy, it was revised in 2017, okay? So they moved the focus from anaphylaxis alone to allergy and atopy, but for the sake of time, we are going to attack one specific objective. So you realize that there are three main objectives. Let me stop my screen sharing and then let me take you to the actual objective, allergy and atopy, and I'll show you how it's like MCC QE1 objective. Okay, so let me share my screen so that you see it. And then when you are done, you know that you've covered the whole thing. So if you come there, if you come here, this is it, allergy and atopy, okay? And if you come to the enabling objectives, you realize that there are three things. If you want to know that you've covered this topic completely, you want to learn objective 1, objective 2, and objective 3. So objective 1 basically is list and interpret critical clinical findings, including history of drug ingestion, food ingestion, stings, environmental and occupational exposures, exercise, or family history, and results of an appropriate physical exam. So if you have somebody with allergy and atopy, you have to be able to go through this objective. What drugs can cause allergies? And remember that I gave you that example of the bee sting. That is just one of them. In other words, this objective also is saying you have to know foods, common foods which cause allergy. You have to know common environmental factors which cause allergy. You have to know common occupational exposures which cause allergy. Number 2, you have to know appropriate use of tests designed to identify allergens. And number 3 is for you to construct an effective management plan, including emergency management of anaphylaxis with appropriate measures. So that's why Dr. Forgotten the first, is it Chidubem, when she was answering the questions, I like the way she went through it. IV epinephrine can be used, but you don't use that ahead of IM epinephrine. And there are indications for the use of IV epinephrine. And you don't give steroids first, you give IM epinephrine first, okay? And then remember that when I was going through the answers, I talked about the fact that when a patient has had allergies or anaphylaxis, you still want to refer them for allergy testing. So those are the objectives you need to go through. So if you are learning, you want to make sure that you've reviewed all those ones. So now let's go back. Let's go back to the notes I have for you. We are just going to deal with the third objective. Construct an effective management plan, including emergency management of anaphylaxis with appropriate measures, and long-term management, including patient education, counseling, and reassignment or removal from work, avoidance of triggers. So this is the lesson. Anaphylaxis is a life-threatening condition. It is because of systemic hypersensitivity. Okay, I'm continuing. Systemic hypersensitivity. You've got to know your stuff. The issue with anaphylaxis is that it can cause rapidly life-threatening airway concerns. It can also cause breathing concerns like bronchospasm, and it can cause circulatory concerns like hypotension and tachycardia. Our patient had developed tachycardia, the patient we did in the question. The patient was developing some airway edema and bronchospasm. Dr. Priya, do you remember that? Do you remember that, Dr. Priya? Because you were drawing some analogies there. Okay. Now, other associated features of anaphylaxis is that there can be urticaria, there can be mucosal changes, there can be stridor, there can be wheezing, there can be hoarseness of voice, there can be skin erythema, pruritus, that is when the skin is itching, swollen eyes, subconjunctival edema or injection. If it becomes very bad because of the hypotension, they can develop syncope. They can even have nausea and vomiting. In fact, you know what? There are 3 definitions of anaphylaxis, but I'll come there. But the objective also wants you to know the triggers of allergies and anaphylaxis. So what are the common triggers? Food like nuts, shellfish, insect stings, drugs like penicillins, NSAIDs, and ACE inhibitors, radiographic contrast media, blood products, and even latex. And that is why in Canada now we've moved away from latex gloves to non-latex gloves. Now, the interesting thing is this: food causes more anaphylaxis in younger people, and medications cause anaphylaxis more. I'm saying commonly. I'm not saying that if there's an adult, food cannot cause anaphylaxis, but I'm saying commonly food, because you know, there are lots of the foods the young person has never been exposed to. So the mother does not know if my child takes peanuts, will she develop anaphylaxis or not? Okay. Good. Now, how do you make a diagnosis of anaphylaxis? There are 3 ways to make a diagnosis of anaphylaxis. 3 ways to make a diagnosis of anaphylaxis. How to make a diagnosis of anaphylaxis? You can make anaphylaxis is likely one of the 3 following. So now, the first scenario is that you can have a patient who has an acute onset of illness, okay? That is minutes to several hours, which involves the skin, the mucosal tissue, or both. So it could be like a person has urticaria, like generalized hives, pruritus, flashing, swollen lips, and at least one of the following. So if you see skin and respiratory issues like dyspnea, wheezing, bronchospasm, stridor, reduced peak expiratory flow, hypoxemia, or if the patient has skin issues like hives with reduced blood pressure or syncope, that is anaphylaxis. So it is not every anaphylaxis where you say, oh, the patient can't breathe. At times it can just be urticaria with hypotension, anaphylaxis. Urticaria with collapse, anaphylaxis. Please, are you following me? Good. Number 2, the case can also be presented as 2 or more of the following that occur rapidly. So, for example, if you know that the patient has a known allergen, like if this patient gets close to horses or a cat, or if the patient eats nuts, and the patient develops so known allergen plus skin anaphylaxis, known allergen plus respiratory compromise, anaphylaxis, known allergy plus decreased blood pressure, anaphylaxis, known allergy plus even cramping, abdominal pain, and vomiting, anaphylaxis. This is from up to date. Are you getting me? So don't be tricked that every anaphylaxis patient has wheezing, can't breathe. No. He says, oh, the patient has allergies to peanuts, and after taking the peanuts, the patient developed generalized hives, which is not responding to diphenhydramine, anaphylaxis. Number 3, if the patient develops reduced blood pressure after exposure to a known allergen, anaphylaxis. Reduced blood pressure in adults is defined as systolic blood pressure less than 90. That one, I'm not going to go into that, okay? And this is also a way to calculate blood pressure in children. So in the exam, if you are given a blood pressure in a child, any systolic blood pressure in a child who is less than 1 year, which is less than 70 millimeters of mercury, that child is hypotensive. So if the child is 1 year or below and systolic blood pressure is less than 70, that child has hypotension. If the child is between 1 year to 10 years, okay, how do you know that the child is hypotensive? So it is 70 plus 2 times the age. So if the child is, say, 2 years, okay, then it is 70 plus 2 times 2, that is 74. Any systolic blood pressure less than 74, that child is hypotensive. Please, are you following me? Everyone is quiet. Dr. Priya, let me pick on you because you have really engaged me today and I really like it. So Dr. Priya, let me give you this question. If you have a 7-year-old child and the blood pressure is 75 millimeters of mercury systolic, is that child hypotensive or not? Tell me.
So that will be 70 plus 14, which will be 89, which is right.
No. So I have a question. The child's blood pressure is 75. So is the child hypotensive or not?
No.
Yes.
Dr. Priya?
Yes, yes.
Oh, yeah. So the blood pressure should be 89, but it is 75 now, so it is hypertension.
Exactly. Okay, Dr. Priya, let's try another one. You have a 6-year-old child. The blood pressure is 85 systolic. Is the child hypotensive or not?
Yes.
So what should the lowest blood pressure be that you will say the child is not hypotensive?
So 6 year 12, 82.
Beautiful. So if the child, so you said the child is hypotensive, but if 85 is not hypertension, okay, let's try this. 10-year-old child, blood pressure is 79 systolic, hypotensive or not?
Yes.
90. Yes.
Right.
You should be 90.
90.
So this is 70.
So now, Dr. Priya, even if you are asleep and Dr. Bruni appears in your sleep and says, Dr. Priya, I have a 6-year-old child, this is the systolic blood, you can tell me whether it's hypotensive or not, true or false?
Yes, 100%.
Beautiful.
Age.
So now you've learned another trick. And that is why I'm saying that, when you are learning, you want to draw connections. You don't want to just, I've learned anaphylaxis. Now I'm going to learn. No. Through anaphylaxis, we've learned blood pressure calculation. We've learned dim phases, how to generate differential diagnosis. Okay. So now there are lots of signs of anaphylaxis. So let's start with the skin. They can have generalized warmth, pruritus, flashing, urticaria. Okay. And then if you go to the lungs, they can have angioedema, they can have wheezing. We said that anaphylaxis can even present as nausea and vomiting. They can even have GI bleeding as part of the presentation for anaphylaxis. So now the objective now says, after you've learned all these things, Dr. Ruby, Dr. Priya, all 73 people on this call, you must be able to manage this patient in the emergency room. Emergency management of anaphylaxis. So what is the emergency management of anaphylaxis? Every emergency medicine case, make sure airway, breathing, circulation is sorted out first. But in anaphylaxis, while you are dealing with airway, give your IM epinephrine. And if there is any medication dose you should know, it is medication dose for epinephrine for anaphylaxis. You can forget about every other dose, but don't forget about epinephrine dosing in anaphylaxis. Okay, so it is 0.5 milligrams IM into the lateral thigh. And with pediatrics, it is 0.01 milligram per kilogram of the 1 in 1,000. Don't say 1 in 10,000, 1 in 1,000. And then you want to put the patient in the reverse Trendelenburg's position so that the blood can flow to the brain as well. This modern medicine is moving away from that. You want to give your oxygen You want to set your IV lines, okay? You want to set your IV lines and then give fluids if the patient is hypotensive. Then adjunct medications you want to give are diphenhydramine, ranitidine, methylprednisone, and salbutamol if the patient has wheeze. But these ones should not lead the way. You should give your epinephrine first. And typically, after you've done that, don't just send the patient home. Keep the patient in the emergency room for about 4 hours, 4 to 6 hours, because they can have what you call a biphasic reaction. But if the anaphylaxis was very bad, then you can observe for a longer period. Yes, Dr. SS, please ask your question and then let's round up. Please ask your question quickly.
Yes, just want to know the same clinical scenario. If I met let's say I have an anaphylaxis patient came in and in the clinic setting, not in the hospital setting, will the answer will be different? I send it to the hospital or just manage in the clinic?
This one, most of the time, the clinics have EpiPen. So that is another thing. Most of the time, we have EpiPens in the clinic. We have EpiPen in the clinic because, you know, in the clinic, we give immunization. So we also have a kit so that if the person has allergies or anaphylaxis to the immunization, you know, we can give it. So in the clinic, we have EpiPen. So that one you can give it in the clinic. But after you give EpiPen, the patient has to still go to the emergency room. If a patient has anaphylaxis at school and they give EpiPen, still the patient has to go to the emergency room. Now, what's the long-term management? This is going to be our last teaching slide. You want to evaluate and identify the trigger. You want to refer the patient to an allergist. You want to educate that symptoms can recur. And if the symptoms recur, they should come back. You want to give a prescription of EpiPen or an auto-injector, preferably two, maybe one at home, one at school, or one at home, one in the bag. You want to inform the patient that if the symptoms recur, they need to use the auto-injector. And after they use the auto-injector, they have to come to the emergency room. They have to be given an anaphylaxis action plan, and they have to follow up with their family physician within 24 to 48 hours. They can be given some cetirizine, some Benadryl, and some prednisone for about 5 days to prevent a secondary reaction. So doctors, after you've gone through all these, then you know that you've really reviewed just the third objective out of atopy and allergy. All right, so you've got to take your time to now review the rest of the two.